So it's a distinct honor for me to introduce our keynote speaker this morning, and in order to facilitate discussion, I'm going to keep my introductions very brief. We have bios on each of the speakers that you can read, and if I spend time talking about all their accomplishments, there wouldn't be very much time left for the interaction. So up until about a year and a half ago, Bill Dietz was the director of the Physical Activity and Nutrition branch for the Centers for Disease Control. And I was teasing him last night that it's a good thing he retired about a year and a half ago, otherwise I'd be forced to give the keynote, and nobody wanted to hear me do that. Before that, he was a professor of pediatrics at Tufts University. He's a member of the Institute of Medicine, which is a very high honor in our field, and has won numerous awards, and we're very thankful. And I use the fact that he retired from the CDC as just a segue to all the work that he's doing now in other areas, so he's clearly not retired. And we're delighted that he's here to give the keynote address. Bill.
Well, thank you, Art. It really is a pleasure to be here. And you, as I've told you several times, have done a superb job in putting together this conference, and I'm just sorry that I won't be able to stay for the whole conference. I'd also like to acknowledge Ellen and Crystal, who have really worked tirelessly behind the scenes to make this as smooth a transition in terms of transportation and hotel stays as possible. Today I want to accomplish 5 or 6 things. I want to begin with a review of where we are with respect to the obesity epidemic, and then turn to the role of physical activity in the prevention and control of chronic diseases. I'll then turn to the current levels of physical activity and the opportunities for changing physical activity in the lives of children, and spend a substantial amount of time on strategies to increase physical activity. Oops, this is not working. Do you want to just advance from over there? Okay. So we really are in a new place with respect to the obesity epidemic. These are data from the Pediatric Nutrition Surveillance System, which is a CDC survey that was conducted by my division, and really surveys low-income children, and primarily in WIC. About 85% of the children in this survey are in WIC. And up until between 2001 and 2010, we saw a flattening of the obesity curves in every group but American Indians and Alaskan Natives. And more recent data that were published a couple of months ago from this same system in 2011 showed that there were substantial and significant decreases in the prevalence of obesity in the 2 to 5-year-old age group in 18 states and 2 territories. There were only significant increases in the prevalence of obesity in 5 states. So there's already a positive trend in the youngest children in our country. Next slide. We're seeing much the same thing in the National Health and Nutrition Examination Survey, which is a representative survey of the U.S. population in girls. You can see here that the curve in girls is also flat over roughly that same time period that we saw in the Pediatric Nutrition Surveillance System. In contrast, the prevalence of obesity is continuing to increase in boys. And one of the interesting phenomena here is that if you take away the African American boys from this survey, the curves in boys are flat, suggesting that what is driving the obesity epidemic in boys is the increase in obesity in African American boys. The next slide shows that there are very hopeful trends around the country. A number of states, a number of locations are showing decreases in the prevalence of childhood obesity. Not universally so, this isn't across the country, but these are very hopeful trends. But the concern here is that in many of the places where these decreases have occurred, they've only occurred in the white population, suggesting again that the disparities are widening, and that unless we address these disparities, we're not going to make a lot of progress with respect to the epidemic. The bad news is that 17% of children and adolescents in the United States are still obese. And the other bad news is that when we limit our investigations to severe obesity in children and adolescents is still increasing. So the obese The overweight groups are relatively stable, but severe obesity is increasing. Next slide. Now, the target for our interventions was nicely established by a paper by Claire Wong that she published in the American Journal of Preventive Medicine in May of 2012. And she looked at the energy deficits necessary to achieve the Healthy People 2010 goals by 2020. These energy deficits were necessary to, or what was required to get kids back to a prevalence of 5% in the 1970s. And you can see here that these deficits are relatively modest, particularly in the youngest age group, 30 calories, roughly 30 calories a day over the next 10 years, well, 7 years from now. About 150 in 6 to 11-year-olds and 177 in 12 to 19-year-olds. Now, these are the deficits necessary to return the mean BMI to where it was. The energy deficits necessary to treat obesity are much greater and are not going to be achieved by the kind of deficits that we're going to achieve, and I'll share with you from the policy and environmental modifications that we're going to talk about. These severely obese individuals with major energy excesses on board are really going to require an aggressive clinical approach. And I'm not going to address that today, but I need to differentiate that because the focus on today is going to be on prevention and improving the health more generally of the population. Next slide. The role of physical activity on morbidity and mortality in the lifespan is going to be discussed in much more detail by Russ Pate in a talk later this morning. But I show this slide only to indicate the role of physical activity related both to the morbidity morbidity in childhood and the risk factors associated with inactivity, namely cardiovascular disease risk factors and glucose tolerance. But also to show you that both the morbidity in childhood gets translated into morbidity in adolescents, morbidity in adults, and mortality in adults. And physical activity also has a role. Inactivity persists through adolescence and adulthood in the same way that physical activity persists in childhood through adolescent and adulthood. And this, the importance of physical activity in chronic disease prevention was emphasized by a meta-analysis in the British Medical Journal that appeared in the last several weeks, which showed that the impact of physical activity on chronic disease risk factors, like cardiovascular disease or like prediabetes, was as important, as powerful as medication use for those diseases, and much less expensive. So it's really one of the first papers, I think, that has convincingly showed that an investment in physical activity is at least as powerful as a medication treatment for, for these chronic diseases. Now, what are we aimed at? Well, these are the physical activity guidelines for children and adolescents established in 2008. We should be shooting for 60 minutes or more of daily physical activity that should be moderate or vigorous intensity, and at least vigorous activity 3 times per week. In addition, that activity should include muscle strengthening activities and bone strengthening activities at least 3 days a week. And it's very important that these physical activities should be age appropriate, enjoyable, and offer variety. So where are we with respect to meeting these guidelines? Well, we're not doing too well. These are data from the Youth Risk Behavior Surveillance System that CDC conducts. And you can see here that a substantial number of children are not getting that 60 minutes on a previous slide, please, on a daily basis. And that's true whether you're talking about middle school or high school students. Now, the Youth Risk Behavior Surveillance System is a self-report system. It's not the same as measured physical activity. The next slide shows what those levels of physical activity are determined by accelerometer in 2 different studies, one from California, which is actually a national study, and the National Health and Nutrition Examination Survey. And you can see here that when physical activity is measured directly by accelerometer, that only about 30% of 16 to 19-year-olds are meeting that 60 minutes per day. In fact, most of them are down around 20 to 30 minutes per day. And the two other findings, particularly in Nader's study of early child care and development, indicates that boys are more active than girls. And interestingly enough, activity on weekdays is greater than activity on weekend days. It's more skewed on weekend days. So some children are getting a lot more physical activity. But by and large, physical activity is limited to the weekday. Now, one of the nice things that Educating the Student Body, the IOM report on physical activity in youth showed was a very nice portrayal of the opportunities for physical activity in a school day. And this diagram indicates that there are really three major opportunities. One is before school, the second is during the school day, and the third is in after school time. So if we look first at before school, what we're talking about here is the likelihood that children are next slide please, likely to walk or bike to school, that this is an opportunity for physical activity. And these are pretty old data. They show the data between 1969 and 2001. Unfortunately, we don't have more recent data, but you can see that very few children who live 2 miles away from school are walking or biking to school. But there's a much greater likelihood that physical activity will occur if children live less than a mile from school. But overall, only about 15% of children in 2001 were walking or biking any distance to school. And this is a consequence of at least two factors. One is safety. So when I lived in Boston and ran a weight control clinic at Tufts, one of the questions that I would ask kids who lived in the city was whether they walked to school. And in many of the inner city neighborhoods in Boston, it was too dangerous for children to walk to school. So even if they lived 3 or 4 blocks away, their parents would drive them to school. That's a lost opportunity. A second factor is that the way our communities are designed has changed substantially over this period of time. And Atlanta is really ground zero for this. You couldn't walk to school even if you wanted to because of the busy highways, the lack of safe crosswalks, and the intense traffic. And even driving kids to school means that traffic jams are considerable, and there's a lot of wasted time and effort. Now, the school day really deserves to be a major focus for physical activity, beginning with physical education and followed by recess and breaks and classroom breaks for physical activity. As we all know, the frequency of school physical education programs is limited. Very few schools offer daily PE, and only a slightly larger number offer PE on the basis of 3 days per week. These are data from the School Health Policy and Programs Survey, also conducted by CDC. And unfortunately, all we have is district-level data. These are not really school-based data, because no school-level data could be collected on schools in 2012 around physical education. Next slide. One of the positive changes we're seeing is increases over the time between these two surveys, 2006 and 2012, in the frequency of required or recommended recess. About a 50% increase in schools that were offering 10 to 19 minutes per day of recess, about a 25 or 30% increase in those that were offering 20 to 29 minutes of recess. But notice that the level of recess, the frequency with which schools offer recess, is still low. 70% of schools are not offering recess. Next slide, please. And when we look more carefully at which schools those are that are not offering recess to first grade students, we again see very substantial disparities. That schools that have an increase in minority enrollment, schools that have an increase in poverty rate, or urban schools are less likely to offer recess than their counterparts, either with lower percentages of minorities, lower rates of poverty, and less urban kinds of settings. suggesting that recess is becoming a luxury for children, not a requirement for children. Next slide. Now, activity breaks, which, as I'll show you in a few moments, is a promising strategy for increasing physical activity, have stayed relatively flat. They're more likely to be offered in elementary schools and certainly less likely in middle and high schools. This is a lost opportunity because, as the next slide shows, the energy costs for physical activity in schools are quite significant for those three main targets. That mandatory physical education would increase caloric expenditure by about 37 calories per day. Classroom activity breaks are not far behind, 33 calories per day, and walking or biking to school is about 27 calories per day. There was no, I would guess that recess is comparable to the classroom activity breaks in this study, although it was not analyzed. And these energy costs are, I think, quite helpful because they begin to help us prioritize what the best investments are around physical activity during the school day. Next slide, please. The other thing that we know about physical activity in schools is that they are extraordinarily effective. They increase physical activity significantly, 5 to 45 minutes per day. Interestingly enough, they have a spillover effect into TV time, in reducing TV time from 5 to 60 minutes per day. As we could expect, there are increases in VO2 max, and participants in school-based physical activity are 3 times more likely to engage in moderate to vigorous physical activity. So there's a sound rationale for an investment in these school-based programs. Now, the other area that offers opportunities for school-wide physical activity is after-school time, both with respect to sports and after-school programs, and I'll show you some data on each of those. This, I hope you can see the lower line, which is the participation of girls in sports over this time period. You can see that there was a significant increase after Title IX was passed, but girls' participation in sports is still lower than boys' participation in sports. Once again, next slide, when we look carefully at what schools provide support for participation in sports, we again see disparities. That those schools with few facilities to support sports have much lower rates of participation, as we might expect. And it's likely that those schools are the same pattern of schools that I showed you in the earlier slide on recess, more likely to be urban, more likely to be minority, more likely to be impoverished. One of the promising areas is a program, next slide, that Chris Economos' group, CO180, Child Obesity 180, was able to negotiate with these major out-of-school groups. These groups account for a significant proportion of the out-of-school population, and therefore getting these schools to agree to these 3 very modest principles, that is, drink right, meaning substitute water for sugar drinks, snack smart, using fruits and vegetables rather than other types of snacks, and move more, have an enormous potential to change the nutritional status and physical activity patterns of youth involved in these programs. And just to give you an example of what the potential impact of this would be, I have 2 very active and sports-playing grandchildren in Boston. And 2 years ago, when they were 5 and 8, I was in Boston on a weekend and went to their soccer games. And as you know, this youth soccer is a big sport. And the quarters, I think, were about 10 to 12 minutes, something like that. And of course, because of, quite rightfully, they don't want all children, the best athletes on the field all the time. The children tend to alternate quarters. So a child is actually only playing 2 of those quarters. And after that those soccer games, they were in different leagues, both boys got in the car holding a juice box, a bag of chips, and a package of cookies. And I calculated that. That was between 500 and 600 calories. for a very modest caloric expenditure that was probably 1/6 to 1/7 of that. So this is an important opportunity. And although in Child Obesity 180, we were able to get agreement on these strategies at the highest level of these organizations, the CEOs of these organizations, what's proved enormously difficult is to translate this down to the local level. That there's a real gap between what the national organizations agree to and the ability to translate that into actionable strategies that really begin to change that juice box, those cookies, and those chips at the local level. Nonetheless, this is a very promising approach, and one which we at Child Obesity 180 were very reluctant to give up without more intensive efforts to translate this at the local level. Now, how do we begin to increase physical activity in youth? Well, the general message here is that we know a lot more about what we should be doing than we do about how to do it. So the new physical activity guidelines, so the mid-course report, was issued last year. And that report recommended the following types of strategies. Next slide. These include, they concluded that there was sufficient evidence to support the introduction and implementation of a multi-component physical activity program in schools that could address the physical education, recess, and classroom activity breaks. And certainly a physical education program alone was a recommended strategy to increase physical activity. There was suggestive evidence for active transportation to school. That was, as you remember, third on that list of caloric costs. A suggestive evidence of early care and education, I'll come back to that in a few moments, and suggestive evidence that the built environment could increase physical activity in youth, and that there was emerging evidence around activity breaks. Next slide. So how do we begin to implement these programs? Well, I think one of the things that we have to do is to improve the research base that links physical activity and behavior, physical activity to classroom behavior and academic performance. And Chuck Hillman is going to discuss this in much greater detail later this morning. But those are cogent reasons to promote physical activity, both to engage parents and to engage teachers. We also need to begin to convene all the relevant groups to develop and implement a strategic plan. One of the characteristics of this field is that there are dozens of groups that are invested in the promotion of physical activity in children and adolescents. But there's no cohesive strategic plan that unites these groups. And that's an important opportunity. And that we know that, next slide, that that parents may be one of those sources, because parents understand that physical education is as important as other subjects, and that there should be more PE in schools, and that a large number believe that PE would have an impact to prevent or control childhood obesity, and that physical activity helps children do better academically and should be part of the K-12 curriculum. The National Physical Activity Plan, which, next slide, which Russ Pate chairs, offers some of those strategies that, on which we should focus. That includes requirements for standard-based physical education, class size and certified physical education teachers, national, local, state, and national standards for physical education, and federal legislation to require school accountability. I can say, I think with some assurance, that the federal initiatives are unlikely to occur, which pushes us back into state and local initiatives. As shown in the next slide, those echo some of the federal initiatives that we need to mobilize funds to assure that schools have the resources. As I showed you earlier, under-resourced schools have less participation in sports. And that we need state-level policies to monitor quality and quantity of these programs, as well as requiring school districts to measure the impact of what they're doing. Now, as we think about this, there are the state level, and even for that matter at the federal level and local level, there are legislative, regulatory, and litigation approaches to this problem. I'm frankly not sure that we're going to get very far in the regulatory approach, nor do I see any litigation emerging that would force, that would sue the schools to implement physical education and get them to do it. Virginia is notable because John Miller, who's a senator here, introduced and passed legislation to require physical education programs in elementary and middle schools last year, surprisingly, in a divided legislature, which was vetoed by the governor. And I suspect that the governor would not have vetoed that legislation if there was a substantial movement from below that engaged parents around this issue or that engaged teachers around this issue. Schools in this country have always had a history of local engagement and local control. And I think that's where we need to begin to mobilize both teachers and parents. I think there's an important general challenge in the mobilization of parents, because overall I think parents feel disempowered, that they feel that anything they do is unlikely to affect substantial change. And I think what we have to remind parents of is that their children's health, welfare, and learning capacity is at stake. And we need to do a much more convincing job of that. And the other piece that we need, I think, as a factor in understanding how to mobilize parents is the qualitative research to understand what parents are going to be most responsive to. What is the message that is going to sufficiently engage parents around this issue? How can we convey the gravity of the threat of inactivity to parents? And I think that a much more cogent and immediate concern is the impact of physical activity on learning or behavior, not long-term disease outcomes, not obesity. And that means that in order to be effective here, we need to think about co-benefits of physical activity and how we partner with other groups other than the health sector in order to implement this. Next slide, please. I mentioned that I would just touch on the early care and education setting. Diane Ward, who's in the audience, is going to be speaking about this later. But using the quality rating improvement system, which are a series of standards against which programs can measure themselves, state and local policies offers promise to implement physical activity standards in early care and education. This is an important opportunity, as the next slide shows, because large numbers of children spend time in some non-parental care arrangement, early care and education. And 60% of children whose mothers are employed are in these settings, and a large number of preschool children are in child care for substantial amounts of time over the course of a week. And one of the interesting phenomena here is there's widespread mobilization around the country around early care and education initiatives, that the role of nutrition and physical activity has hit home there. But a lot of these initiatives have yet to come to fruition, in part because the people who administer child care are often not themselves active or don't understand the value of improved nutrition or physical activity. So here are a few strategies by which we could increase physical activity in early care and education. One is to provide play equipment on playgrounds and open spaces. We also know that children who are outside, young children who are outside, are more likely to be physically active than when they are indoors. So getting children outside and with resources will increase physical activity. Staff training is an important element of this, and as I mentioned, the importance of physical activity for staff, or the importance of showing staff that physical activity makes their jobs easier because they're going to see fewer behavioral problems, is an important strategy to pursue. And finally, integrating physical activity into learning and teaching activities is consistent with the education part of early care and education. Next slide. The final area that I think is also neglected is engaging providers at all levels in exercise and medicine. This is an important opportunity for counseling. And providers tend to see changes in behavior around physical activity as a much more challenging issue than simply prescribing a pill. But I would remind you that beginning to take a medication is a behavior change. And we don't do very well there either. There is a very high rate of non-compliance with medication use. And so I think that this aversion to counseling around physical activity and thinking that it's harder to do that for physical activity than it is for medication change is really a myth that reflects provider discomfort with how to do it, how to have a conversation. Next slide, another barrier to counseling around physical activity, which as this slide shows we don't do very well, is that the physician's BMI and the physician's own level of physical activity predicts whether they're likely to counsel around physical activity. There's also a bias around physical activity, even though a lot of practitioners don't ask even their overweight patients about whether they're physically active. There's an increased importance in physical activity counseling across the board because, as I showed you in one of those earlier slides, the level of physical activity in youth predicts subsequent levels of physical activity. So that counseling really needs to start early. And it reflects a broader consideration in medical education, which is that providers are not trained in behavior change strategies, that it's really given cursory attention in medical curricula. And furthermore, providers are not trained in understanding the linkages between public health services and clinical services, and don't recognize that if they're going to increase physical activity or recommend or help patients understand the importance of physical activity, that needs to be complemented by public health approaches that provide the facilities or opportunities for physical activity in the neighborhood. So this is a new direction for medicine. There was a nice paper in Lancet 2 years ago by Julio Frank, which pointed out that those two characteristics, as well as the reliance on information technology, were critical elements of medical education, or more appropriately, health professional education for the 21st century. And to me, that's an important opportunity that's going to have widespread application beyond just physical activity, but extends into chronic disease prevention and treatment. Now, final slide shows what I think is going to be necessary for collective success in this initiative. The first is a common agenda, and I think that's going to require, as I mentioned earlier, a substantial investment in strategic planning. Part of that investment needs to include qualitative research to understand what appeals to parents, what is most threatening to parents about the absence of physical activity, and then a cohesive collaboration for all the groups that touch youth around specific strategies. And I think that those strategies do require some qualitative research, which points to the need for backbone support, that is financial support underpinning these activities. If we're going to be successful, we've got to be able to measure our success, and that means putting in place baseline measures. Now, we have some of that in the CDC studies, like the SHIP study and the Youth Risk Behavior System, but we don't have measurement systems in place for policies across the country. And that's a critical lost opportunity, that we need to have a system of, that helps us understand the progress we're making on the implementation of policy at the state, local, and federal level. We need to look for mutually reinforcing activities, like the co-benefits of physical activity. We may not be able to make the case that physical activity is good for children's health without talking also about the important impact on behavior and cognition. And if we're going to have an effective coalition around this, we need continuous communication. And when we look to other social movements like tobacco, those efforts began at the local level, and innovation at the local level was shared rapidly at the local level and at the state level. So as we move this forward, we need to link these groups together, and we need to find institutions that can accomplish this task. So I think that's the challenge ahead of us. I think that the opportunity is there, that as all of those slides that I showed you related to the National Physical Activity Plan or the Physical Activity Guidelines mid-course report, we know what it is we should do. We know what those programs take. What we don't know is how to implement them. What we don't know is how to engage the necessary constituencies in changing the landscape for children. But the role of physical activity in terms of its economic benefits, in terms of its health benefits, and in terms of its behavioral benefits means that this is an opportunity that we can't let go of, and we must move forward. So I'm looking forward to hearing more about what Youth-Nex next steps are to accomplish these ends. And those of you in the room all, I think, touch part of this system. And it's going to take all of our engagement to accomplish this task. Thank you.